Okay, cool. So last time we did kind of an overview and then we started with the lower grade kind of fibroblastic things. Do we want to continue with the myofibroblastic stuff or swap? I see yeses. All right, we'll keep going and see how far we go. And then right through all of this stuff. Okay, cool. So I think we did these lower grade ones, right? We did the fibromatoses, we did the hypocellular myxoid sarcomas and the SCF. Is this where we stopped? No, we kept going. Did we do synovial? Did we do SFT? We did IMT, we did fibrosar. We did undiff. I think that's maybe where we stopped, right? Yeah. Okay, good. So now we'll go into the other kind of tumors of uncertain differentiation or mixed differentiation that have more of an epithelioid morphology. And so this is that kind of continuing with the more pattern-based approach, right? So we saw the quasi-cellular spindly things, we saw the hypercellular spindly things. Now we'll talk about the plump things. And so one of the first ones I think that we should always remember when we're dealing with a plump thing is a plump or an epithelioid sarcoma. So even though epithelioid is a descriptor, right, in this case, it's the actual name of the tumor. So there is the distal type and the proximal type, both of which have similar immunoprofiles and genetics, but have different clinical presentations and slightly different morphologies. So the distal type is literally like on the distal extremities, fingers, toes, hands, etc. The proximal type is in the deep soft tissue of usually the trunk or the pelvis. The distal type has these nodules that almost, if you look uncarefully, can look like granulomas or like kind of necrobiosis because they have this usually a central sclerotic collagenized core surrounded by the epithelioid cells, which are not histiocytes, right, but those are the tumor cells. The proximal type tends to be much more overtly malignant with these very large kind of pleomorphic epithelioid cells with prominent nucleoli with mitoses, often with kind of this eccentric or rhabdoid type of appearance, right, which we know is common for the chromatin remodeling complex tumors, right? So if you see something like this on the digits or like this, throw on a couple of stains. The most important that's going to be pertinent negative and pertinent positive is these should be positive for keratin or EMA. For some reason, they are one of the keratin expressing sarcomas, but specifically they'll have diffuse I and I1 loss in the nuclei. There's a little bit of immunophenotypic kind of quirks. Some of them have ERG, which can resemble a vascular tumor. Some of them have CD34, which is somewhat more nonspecific. But these are generally of high kind of behavior, right? They can metastasize both to lymph nodes as well as to visceral sites. The thing about lymph nodes with sarcomas, right? And I think I mentioned this before, is the ones that tend to go to nodes are the ones that tend to have epithelioid morphology. And it's maybe because there's this mesenchymal to epithelial transition and they access the lymphatics in this manner. I'm not entirely sure, but that's kind of the general trend that we see. So that's epithelioid sarc. As I said earlier, your differential diagnosis of the distal type is going to be something like a granuloma annulare or even a rheumatoid nodule or some kind of granuloma in an adult. And in a kid, well, kids don't really get, epithelioid sarcomas, but something that histologically resembles it, right, might be a calcifying aponeurotic fibroma in a kid. All of the three on the left are actual histiocytes, right? They should be CD68, 163, and sometimes SMA positive, but these are not, right? So these have your keratin in your iron loss. A tumor that is essentially extremely morphologically and genetically similar is a malignant extrarenal rhabdoid tumor. But this differs mostly in its clinical presentation and location. So this is the tumor that the kids get. So this is usually in the deep kind of axial or paraspinal region in kids. Also in some primary visceral sites, right, like liver. This is identical to the CNS rhabdoid tumor. This is identical to the renal rhabdoid tumor, but it's sort of named depending on where it's located. But they all have these pleomorphic rhabdoid cells. They all have essentially keratin positivity, right? And they all have INI1 loss. So it's kind of the epithelioid sarcoma that's called an extrarenal rhabdoid tumor in a child in midline locations or kidney locations or brain locations. Some of these kids though have familial presentations of germline SMARCB1 mutation. This is not true. This germline thing is not necessarily true for the adult epithelioid sarcoma patients. So kind of a slightly different in that regard as well.
Are the epithelioid sarcomas negative for CD99? Does that ever get thrown on?
Yeah, no, that's a
or S100.
They are not consistently positive for either. So I wouldn't rely on those as markers to prove that that's what it is. But for example, if you see it in this type of tumor, it's okay. It's just not diagnostic. The overlap, yeah, exactly. I actually don't know how much CD99 has been evaluated in epithelioid sarcoma. But it really should be, for all intents and purposes, not S100 positive. If you see some weak CD9, I would not know what significance to attribute to it. Exactly, the Venn diagram. Well, sometimes we ask ourselves, like, why is this even called a sarcoma when it's keratin expressing and epithelioid, and you could see it in, well, because it's in the, maybe because it presents in the soft tissue, right? Like it's not presenting in an epithelial site, but you know, we can get into the politics of epithelioid sarcoma at another time. So of the INI1, SMARCB1, or you know, BRG1, SMARCA4, epithelioid sarc is the prototype, right? The rhabdoid tumors, renal medullary carcinoma, don't forget about that. And then some of the myeloepithelial neoplasms or even epithelioid MPNSTs have been shown to have INI1 loss. So in some cases it's disease defining, you know, and in some cases it's just happens to be present at random. So this is kind of the overview of these in terms of which tend to have the INI1 loss and which tend to have the BRG1 loss. You've got some uterine and ovarian tumors, and then this thoracic neoplasm that tends to be BRG instead of INI. Histologically similar but structurally different is going to be alveolar soft part sarcoma. So this is also more of a tumor of younger patients, and actually often presents in the head and neck. So you can see these in the tongue, but you can also see them in the somatic soft tissues of the extremities. So the morphology here is as it's described, right? It tends to be nested or alveolar with this kind of almost slightly discohesive polygonal cells in the center with this granular cytoplasm and prominent nucleoli, right? So the difference here is that it's nested, otherwise very, very similar to the others that we've seen. It has these, for boards takers, right? They like to show some of these classic markers like PAS positive sort of shards in the cell, which correlate to these rhomboid shaped granules on electron microscopy. Not that we use those anymore now that we have genetics, but in historic days, that would help essentially diagnosis of this tumor. Now it's genetics, right? So it's TFE3 rearrangement and nuclear TFE3 immunoexpression. So we do have TFE3 here as an IHC stain. There's really nothing significantly specific otherwise for IHC. Some of them can have maybe a little bit of Desmond or S100, but really nothing, not uniformly. So really morphology and TFE3 are diagnostic here. And yep, these can metastasize and are generally considered high grade. Clear cell sarcoma is a little bit more appearing as a melanoma, and it formerly was called malignant melanoma of soft parts, meaning this was thought to be a melanoma arising in the soft tissues without being in the skin at all. Because kind of looks like melanoma, right, with nests and spindle cells, even with these wreath-like or rosette-like giant cells, with prominent nucleoli, and it was positive for HMV45, S100, MLNA, MITF, right? But lo and behold, it doesn't have the same genetics as melanomas, right? These have EWSR 8F1 rearrangements. They don't have the characteristic BRAF, NRAS, et cetera. They don't have sun exposure. They're deep, right? And they tend to be also in younger patients that don't of a non-melanoma age, really. This is also something that you often see in the distal extremities, right? So we talked about distal epithelioid sarc. Clear cell sarc is also one that happens in the distal extremities. So think about this when you have something of this appearance in a younger patient. They say that HMB45 is somewhat stronger than S100, which may be a clue, right? That this isn't a melanoma, because usually S100 in melanomas is really strong. So just take that with a grain of salt. And oh yeah, lymph node mets. All right, PCOMAs or perivascular epithelioid cell tumors. You're probably more gonna deal with this in the GYN tract, but remember that these can sort of present anywhere and everywhere. And they're in a family of tumors that are of hybrid kind of myogenic and melanocytic differentiation. So this is like angiomyolipoma of the kidney, the clear cell tumors of lungs. I don't know if that name is still applicable today. Those of you who know lung, you can let me know. Lymphangioliomyomatosis and PCOMA, right? So perivascular epithelioid cell. So when we think about pericytes, right, what do pericytes express? They're the contractile cells around the vessels, so they should have some myogenic markers. And then this aberrant melanocytic, but only rarely S100. Similar appearance of epithelioid, rhabdoid, delicate vasculature, sometimes clear, sometimes pink. All right. So here's your differential diagnosis of the epithelioid cells. As you can see, a lot of them, right? A lot of them express keratins too strong or kind of middle range. Many have I and I1 loss, and the rest you can fill in. All right. When you think about tumors that either have melanocytic or S100 SOX10 expression, your differential kind of narrows to this outside of just frank melanoma. So sometimes you'll need genetics and other immunoprofile, right, to sort these things out. MPNST, honestly, epithelioid MPNST can sometimes be one of the hardest ones to diagnose because it's basically got melanocytic markers, right, but lack of melanoma genetics. And sometimes, right, we know that not all melanomas express all melanoma markers at all times, right? And so sometimes we've had to rely on genetics or clinical history or nerve association, et cetera, to help us define the difference between those. Did that all make sense? Comments, questions? Okay. So now a slight morphologic shift here of epithelioid tumors that also specifically have myxoid stroma. And there are only a few of these, which is good. So when you see this kind of pattern, you really are narrowed. So the first one we'll talk about is our myoepithelial tumors. And so you remember myoepithelial cells a lot, right, in the head and neck and salivary gland. But remember that myoepithelial neoplasms can occur also in soft tissue as primary soft tissue tumors. They can occur in bone, right, as primary bone tumors, and they don't have to have anything to do with any epithelial or salivary types of tissues. But they look similar in terms of they tend to have these kind of nests or cords or like lines of plump cells with eosinophilic cytoplasm in this kind of myxoidy bluish matrix. They have to show one of two groups of stains, right? They have to show some epithelial marker like keratin or EMA, and they have to show some kind of myoepithelial marker. In the soft tissue, the myoepithelial expression profile is somewhat different than in the salivary, right? So in the salivary, we think a lot about P63, P40, SMA. Here, it's less of the P63s and P40s, but it's more of the myeloid markers like calponin and SMA, S100 or SOX10, and even GFAP. That's why a panel of immunos is often used for myoepithelial expression. As I said earlier, in some malignant cases of myoepithelial tumors, you have INI1 loss, or EWSR gene rearrangement. So these are overlapping genetics of myoepithelial tumors. How do you make a difference between a myoepithelioma and a myoepithelial carcinoma or a malignant myoepithelioma, right, in soft tissue? And it's been determined that the most important factor is not the presence of invasion, because you can have bad aggressive tumors that are relatively circumscribed, but it's cytomorphology, right? So it's apoptoses, mitoses, prominent nucleoli, necrosis. So these are indicators of malignancies in soft tissue tumors, which is slightly different, perhaps, than we are normally used to in the epithelial world. So not invasion, but cytomorphology, and that predicts behavior. Sometimes what we now know is myoepithelial tumors that arise in the soft tissue, right, that have keratin expression, that have S100 expression. Historically, these were called paracordomas. What we now think of that is an actual myoepithelial tumor, but it was previously thought that chordomas could arise in the soft tissue because look at them. They're plump epithelioid cells and nests and cords and pink cytoplasm with all this myxoidy stuff in the background, and they express keratin and S100, right? So before the days of brachyury and before the days of genetics, we thought, oh cool, that's a chordoma arising in the soft tissue. It's not. Chordomas only arise in two locations at the lines of closure of the notochord, right? Because these are notochordal derived cells. So basically the base of skull, or sacrococcygeal kind of region. They often are large and infiltrative, and it can invade the surrounding soft tissues, but essentially they start in the bone where the remnants of the notochord were as these notochordal cell tumors, and then they transform to these essentially malignant chordomas. Even though they may not look malignant, they're all essentially considered bad. So they all have keratin and EMA and S100 and specifically brachyury, but they don't necessarily have, right, the other myeloid markers, right? So that's how they're different from myoepithelial. We don't have brachyury here, but we send it out to Mayo. So here's a distal sort of tail of sacrum with tumor here. These cells were called or are called phytoliparids because they're kind of bubbly, coming from the sort of origins of bladder bearing, right? So they're kind of swollen with these bubbles. They can dedifferentiate into this high-grade malignant spindle cell neoplasm, which is D-diff chordoma, but they should maintain at least the brachyury. Surgery with negative margins is usually what these guys get. But yeah, problem is they can locally infiltrate, they can recur, and they can metastasize. So not a good thing to have a chordoma. The last one is extraskeletal myxoid chondrosarc, and this is probably the hardest one to diagnose because it doesn't have a good immunoprofile. You can't really prove it with IHC because either you're going to have some weaky S100, maybe c-KIT, or nothing. This may stain for nothing. So you have to prove it with genetics, which is NR4A3 rearrangement. But you can see histologically it's kind of similar. These cells are maybe a little bit flatter. They are kind of, again, interconnected in these linear kind of nest networks with this myxoid stroma. So yeah, that's epithelioid, extraskeletal myxoid chondrosarc. Resection wise, they kind of have this lobulated hybrid red and yellow appearance. These can metastasize as well to distant visceral sites. So I think always about these 3 tumors, depending on where I am and what the immunoprofile is. The other kind of tumors that could come into the differential, depending again on where you are, might be a conventional chondrosarc, but these generally don't have that same appearance. They should have more kind of chondroid differentiation. If you're in the right location, you know, you talked to Peter, right, about choroid meningiomas and choroid gliomas, but we don't really deal with these in the soft tissue. That's more intracranial. So I put here a kind of a box, like we talked about, comparing the things that have similar morphologies, similar immunoprofiles, INI1 loss, but different kind of locations and other potential clinical factors that might differentiate them. So what did we talk about? MPNST, myeloepithelial tumors, rhabdoid tumors, epithelioid sarcomas, all of which have sort of differing S100 SOX10, plus or minus keratin, plus or minus INI1. So that's there for your perusal. Okay. 824. So next on this consecutive list is skin dermal based things. Do you want to continue here or jump back to one of the other topics like vascular, adipocytic, whatever? Just keep going. Just keep going. Okay. So, you know, remember that soft tissue tumors, right, can occur in the skin. And so we see, right, we work with derm a lot if and when we need to. So probably the most common thing you're going to see is a dermatofibroma or a fibrous histiocytoma. And so many of us probably already have those little bumps on our legs. These little raised kind of hyperpigmented things. And so when you see them on biopsy, they're hyperpigmented because the epithelial layer above the tumor has basal elongation and hyperpigmentation. And the thing that causes the bump, right, is the spindle cell proliferation in the dermis. It might look scary because it's highly infiltrative, right? It percolates between the dermal collagen. But when you examine it, it's generally relatively bland. It kind of has a storiform appearance. It can have a few mitoses here and there. If you want to prove it, you know, you can do SMA and histocyte markers and factor 13A, which will highlight some of the cells. If you're worried about a DFSP, which I'll show you next, you only generally can have a little bit of CD34 at the periphery, but it shouldn't be diffuse and it shouldn't be strong. The thing to know though about DFs is that there are histologic variants, right? There's very cellular DFs that start to worry you for something like a DFSP. There are these epithelioid DFs. There are lipidized fatty DFs. There are these giant atypical cell ones, or even the deep dermatofibromas that are in the lower dermis, pushing into the subcutis. But they don't tend to be as infiltrative. They tend to be more circumscribed. So just variants of DF to think about. Your differential, as I said, probably most critically is going to be a DFSP. And so this has a very kind of packeted, tight storiform appearance. It can range in cellularity from being very cellular to being somewhat more myxoid almost, or moderately cellular. It should start somewhere in the dermis and generally uniformly invade the subcutis, often in this honeycomb pattern. And what was I going to say? Oh yeah, CD34 should be diffuse and strong. What we should always look for in DFFPs, however, are areas of fibrosarcoma's transformation. So like I said earlier when we were talking, or last time, when we were talking about fibrosarcoma, it's these long sweeping herringbone-like fascicles rather than these short, tight intersecting storiform fascicles. So pattern, right? Cellularity tends to be very high, and mitoses. Generally, they say, you know, it is said about 5 or more per 10 high-powered fields. Also, in these areas, they tend to be weaker or lost in CD34. So those are ways in which you can diagnose fibrosarcoma's transformation. It often is a discrete nodule adjacent to a conventional DFSP, but sometimes it can be more subtle and the line can be not so clear. But the reason to look for it, right, is because they metastasize. In the absence of fibrosarcomatous transformation, they do not metastasize, they just locally recur. But with fibrosarcomatous transformation, they can metastasize, and so then the patient gets staging and potentially chemo if necessary. If you ever can't prove it, like your staining is bad or whatever, collagen PDGFB rearrangement is present, and you can fish or do RNA fusion for that. The juvenile kind of variant of DFSP is this giant cell fibroblastoma. The genetics and immuno are exactly the same, but it's got these weird atypical kind of monstery giant cells with these pseudovascular spaces. These are not true endothelial cells. These are actually tumor kind of giant cells lining these clefts. Similarly, they can recur but not really metastasize, but they're generally in young kids and they have the same staining and genetics. Kids can also get these juvenile xanthogranulomas, which are these kind of orangish patches, these raised patches that are just characteristic, right? With these essentially histiocytes with giant cells just filling the dermis, going right up to the skin. And it's classic. So if you want to stain them, they're again kind of these fibrohistiocytic, just like a dermatofibroma, right? They can stain for histiocyte markers, they can stain for SMA, but you usually don't need it because the H&E is so characteristic. All right, moving into the kind of uglier things. So I want to spend a minute talking about atypical fibroxanthoma versus high-grade dermal sarcoma. So when you will often see this differential present as kind of a shaved biopsy in an older person, often on their head, neck, scalp, or some other sun-exposed site. It's thought that atypical fibroxanthoma characteristically is restricted to the dermis, and may have a pushing border at the bottom that pushes into the subcutis but does not infiltrate. On high power, it looks like a high-grade sarcoma. So it's atypical, it's pleomorphic, it's got mitoses, it sometimes has giant cells, and it sometimes has surface ulceration, and occasionally, sometimes people have reported scattered P63 positive cells in it. So then you wonder, is this really just a non-keratin expressing cutaneous spindle cell squamous cell carcinoma that's ulcerated? Maybe, I don't know. But the thing is, it looks ugly, right? It looks malignant. The problem is the differential diagnosis is an actual high-grade dermal sarcoma that does not behave nicely like AFXs do, but actually can locally recur and significantly metastasize. The difference, right, is that these infiltrate into the subcutis. These can have LVI, PNI, and necrosis, which generally AFXs don't, right? So don't ever make this differential diagnosis on a shaved biopsy where you don't know what's happening in the bottom of the lesion. So, malignant spindle cell neoplasm of dermis, differential is this. If you've excluded that it's not a keratin positive, whatever spindle cell carcinoma, if it's not an S100 SOX10 positive spindle cell melanoma, right? Those are the things you have to exclude. Once you've excluded the other common things that occur in the superficial skin, then you can say, okay, maybe it's between one of these two things, but I only say this with caution because we've had cases that were diagnosed as AFX on the outside and then came roaring back as these giant things that metastasized, and we're just higher grade malignancies. So if you say AFX, you imply it's out, patient's done. Okay, so that's just my word of caution. Now we're kind of shifting into some of the more rare things that I think it's important to think about, but we just honestly see less often because they're less common. One of them is this plexiform fibrohistiocytic tumor that is characteristically in younger patients, right? Kids, young adults, tends to be in the extremities and tends to be slow growing. And what you'll see is this kind of triphasic proliferation of these spindle cells that are either in sort of fascicles or whorls. You'll see these plump mononuclear cells, and then you'll see these background osteoclast-like giant cells, right? So if you were to just take this, you might think it almost looks like a giant cell tumor of bone or a giant cell tumor of tendon sheath. But then you throw in some spindle cells and you throw it in the dermis and subcutis of a young person, then you're dealing with plexiform fibrohistiocytic tumor. The thing with this is, at least when we had early descriptions of this, they occasionally metastasize to lymph nodes. So not a completely indolent thing, kind of these intermediate malignant potential type of tumors where most of them don't, but some of them do. So we are very cautious about it.
Are there no molecular associations with these?
Not that I know of. I would have to double check the current literature, but I don't believe there's anything that's been, if you wanna Google it and let me know, but I haven't seen it. I haven't seen it. So in this giant cell rich tumor kind of thought process, right? What are the giant cell rich tumors that we can see in the soft tissue? Mostly, we're gonna see them around joints, right? So the true tenosynovial giant cell tumors with the characteristic, right? Giant cells, plump mononuclear cells, foamy histiocytes, hemosiderin, right? These are gonna be either localized, used to be called GCT tendon sheath, usually in the fingers, or used to be called PVNS, diffusely coating the joints, more often larger joints like knee, elbow, whatever. So the only way to make this distinction, because if you look at high power and on high power, they look the same, but you need the growth. You need to know if it's generally one nodule or if it's more of a diffuse, like carpeting of the joint in this finger-like process. And you can sometimes see these smaller fragments, right, that are actually lined by synovium. That's helpful. Or you refer to the radiology or the clinical scenario. But just like these other fibrohistiocytic lesions, right, they're positive for histiocyte markers and kind of SMA-like things. So these do have CSF gene rearrangements, but we don't really use that because it's so classic histologically, right? There's some controversy about whether this can actually have a malignant variant. Probably malignant giant cell tumors are just undifferentiated pleomorphic sarcomas that are rich in giant cells because they don't have the same gene rearrangements, et cetera, in most cases, but to be determined. GCT soft tissue is very, very morphologically similar to GCT bone, where it doesn't really have the hemosiderin or the foamy histiocytes. It more has these sheets, right? Sheets of super, super large giant cells with mononuclear cells in the background. And this kind of lobulated appearance that's pretty characteristic. But the GCT soft tissue is pretty rare. The GCTs of tenosynovium are very common. All right, kind of shifting a little bit into tumors that form matrix. So you can have true chondromas of soft tissue, right, that are pure cartilage. They can occur in a number of locations, including, distal digits. They can even occur in the head and neck. But they basically look like cartilage, occasionally with stippled calcification. But if you're not thinking about cartilage because you're not in a bone, right? You can miss these because you might be thinking of something epithelioid, right? Something keratin expressing, especially if it looks like this. But always remember possible cartilage. Myositis ossificans, it's kind of like I like to think about it as a an ossified variation of nodular fasciitis in the muscle. So kind of to just break it down into, it's not really a full, like, how can we combine, I'm not a lumper, I mean, I'm not a splitter, I'm a lumper, right? So it's basically like cellular fibrous tissue with Roby collagen, with extravasated red cells that looks exactly like nodular fasciitis, but at the periphery, it's got this rind of ossification. Oops, and it has USP6 fusion, and it happens to be in the deep muscle rather than in the kind of subcutis. So that's myositis ossificans. It's usually radiographically clear, right? Because it's in the muscle and it has this signal of like an eggshell of bone around it. So sometimes they biopsy it. Versus, you know, the rare, like this is like, I don't know, like a Yeti or like an abominable snowman of extraskeletal osteosarc. Does this really exist? I don't know. The problem is you're dealing with a malignancy, you're dealing with a soft tissue sarcoma, right, type of picture with osteoid. So is this heterologous differentiation? Because we know that things like D. diff liposarc can have heterologous differentiation of bone production and or neural production or myogenic production, right? So I would argue this is a diagnosis of exclusion. Make sure it's not some other high-grade sarcoma with maybe some matrix production. But there have been diagnoses of extraskeletal osteosarc. Ideally, they wouldn't have any other disease diagnosed in genetics, right? Like MDM2, overexpression, whatever. They would probably just have like a P53 mutation, if anything, right? So it's kind of a diagnosis of exclusion. The good thing is, probably doesn't really matter too much because just like other soft tissue sarcomas, they're pretty aggressive. But if you call something osteosarc specifically, they may treat it with the more conventional intraosseous osteosarcoma chemo regimens. But I don't know, I don't think I've ever actually, maybe once or twice made this diagnosis ever, but it's pretty good. Okay, keep going. All right, so now we're kind of flipping gears again into lower grade myxoid tumors. So sorry about the low grade, high grade flip flop, but it's okay, it's good for our brains. So we're dealing with kind of low grade things that have myxoid stroma. So most commonly is going to be myxoma, right? This can be in the muscle, this can be around the joints. Histology is generally very paucicellular with sometimes a little bit of increase, so that's okay. We've made diagnosis of sort of moderately cellular myxomas before. Kind of non-specific fibroblastic, myofibroblastic markers. You want to make sure, right, that it's not a low-grade fibromyxoid sarcoma because it can have some myxoid and fibrous areas, so your EMA and your MUC4 should be negative. If it's really extracellular or you're having trouble making the diagnosis, we've used the presence of GNAS mutation to help us with myxomas, but usually they're pretty characteristic. If you're in the dermis now, rather than the deep soft tissue, and you're dealing with something that looks like a myxoma, you might want to think about a superficial angiomyxoma. So the thing that's characteristic about these are they are also richly vascular, hence angiomyxoma, right? And they entrap skin adnexal structures. And they often have many little neutrophils in them. So a few things that can differentiate them from just a regular myxoma: location in the dermis, entrapment of structures, vessels, and neutrophils. So that's superficial angiomyxoma, which is different from superficial acral fibromyxoma, right? Which differentially tends to be in the kind of around or under the nails, right? So periungual. But similar myxoid infiltration of the dermis, what they don't have are they don't really have that adnexal entrapment and they don't have neutrophils and they are in a periungual location. So that's how you can differentiate them from prior. And they are one of these neoplasms that is of retinoblastoma loss. So I think we skipped over the fatty section, right? But if you remember the primordial kind of thing that we knew about that had retinoblastoma loss was spindle cell and pleomorphic lipomas. So there are other neoplasms that are defined by loss of retinoblastoma. This is one of them in case you need to use that as an adjunct test. These are all different from your deep or your aggressive angiomyxomas. Most often you'll see this probably again also on the GYN service because this is often in a perineum or pelvic location. So the GYN surgeons deal with it. But it again is this paucicellular kind of myxoid to collagenous stroma with richly enriched in these blood vessels, tends to have expression of ERPR, can have HMGA2 rearrangement. What's important though is that it's infiltrative and it's very hard to excise, and so it can come back. But there's really, once you see something like this in that location, your differential is quite narrow. Okay. Similar name, but slightly different morphology is soft tissue angiofibroma. So these are now circumscribed neoplasms that occur in the deep soft tissues of adults, that have this very, I don't know, arguably very nondescript appearance that looks kind of similar to what we've already seen. With these very bland spindle cells in this kind of myxoid to collagenous stroma, you've got some associated blood vessels. Like, well, I don't know what this is. You kind of look at it, you're like, I don't know what it is. Well, it's a thing. It has a recurring genetic anomaly, which is NCOA2 gene rearrangement. And so you can, if you have something that kind of looks kind of nondescript like this and circumscribed, you may want to think about a soft tissue angiofibroma. These are also pretty rare. So this is your kind of spectrum of all of those put in a comparative chart. Okay, so this is our grab bag of sorts that kind of continues on a similar spectrum of fibroblastic things, since we're on the topic. So fibrous hematoma of infancy. This is also one that I think I've heard, I shouldn't say this on recordings, but the boards may like to ask you about, because it's very characteristic. So young kids, generally in the kind of axilla and groin areas, that has, again, this triphasic component. It has these longer, more eosinophilic fascicles of fibrous tissue that are SMA positive. It has these islands of more plump, round, immature mesenchymal tissue that are SMA negative, and it has fat. And it's all part of the lesion, it's thought. Generally, this is cured by excision, so it's a good diagnosis to make in a kid, but it's very characteristic morphologically with this triphasic thing. So this one, so these hemosiderotic fibrolipomatous tumors or myxoinflammatory fibroblastic sarcomas are kind of a weird thing. So the hemosiderotic fibrolipomatous tumors are more reminiscent of like spindly fat, right? Spindly fat with hemosiderin. So spindly fat with hemosiderin in the distal extremities, like the foot, the palms, the soles. You may look at this and say, I don't know, it looks like bloody scar in fat. It's a tumor that has a rearrangement. So if something doesn't make sense and you're in the distal extremities and it looks like bloody scar with fat, think about a hemosiderotic fibrolipomatous tumor. The reason to think about it is because it could transform to a higher grade sarcoma. This in and of itself is really not clinically that significant because it can recur, but what it can do is transform, and then you're dealing with the higher grade sarcoma that can metastasize, right? So this is a spectrum, all of these three, the hemosiderotic fibrolipomatous tumor, the AHFLT with transformation, and then the true myxoinflammatory fibroblastic sarcoma are all kind of related to rearrangements of the MGEA5 gene. What the higher grade sarcoma ends up looking like is kind of like a myxofibrosarcoma, right, with these curvilinear blood vessels, with these spindle cells in the myxoid stroma, with atypical cells. But what they have that conventional myxofibrosarcoma doesn't have is these quote unquote virucyte or Reed-Sternberg-like cells that people looked at in the past and were like, oh my God, is that a viral inclusion, or is it the Reed-Sternberg cell from Hodgkin's lymphoma, right? Because they have this kind of popcorny-like cytoplasm. They often have really prominent single or multiple nucleoli that kind of stand out from the background. So if you see these guys, think about this tumor, especially if you're in the right location, right, which is just distal hands and feet. So that's the spectrum of these types of tumors. And if you want, again, you can prove it with the MGEA5 gene rearrangement. Okay. Another super rare bird that often eludes diagnosis is phosphaturic mesenchymal tumor. It's really easy to diagnose if the patient has known essentially a clinical picture of rickets, which is osteomalacia, right, which is hypophosphatemia, right, and phosphaturia, right? So if this patient presents with that known electrolyte abnormality and they've got a tumor that looks like this, you're good. But sometimes they don't have that clinical serology, or they have it, but it's not known, right? It's not been tested because they present with the mass before the symptoms of osteomalacia. So what this looks like is this pretty blandish spindle cell tumor, but the characteristic thing that sets it apart from all the others is the matrix. And it tends to have this like grungy, they call it grungy calcification, or like smudgy matrix. You're like, is this underfixed? Like, is this normal? Yup, that's what it looks like. So you see some weird matrix with a bland spindly neoplasm. Think about phosphaturic mesenchymal tumor. Look into the serologies, or ask for them to order it. Why does this have this picture? Is because the tumor secretes fibroblast growth factor 23, which is what causes this bony turnover and phosphate problem. And so you can actually do ISH for fibroblast growth factor in the tumor. And if it's positive, it's phosphaturic mesenchymal tumor. Perfectly, as you might expect, the perineoplastic syndrome, right, goes away when you take the tumor out. So most of these patients are cured from all of their disease, the tumors and the clinical syndromes, by removing the tumor. The issue is that in in rare circumstances, I haven't had my coffee yet. In rare circumstances, this can be malignant. It can be hypercellular with higher mitotic activity and can have the potential to metastasize. So just like with any soft tissue tumor, always ask yourself, right, is it worse? Is this one of the tumors that can be of a high grade morphology? And if so, look for those features, look for the mites, etc. Okay, that's phosphaturic mesenchymal tumor. AFH. Angiomatoid fibrous histiocytoma is generally present, again, in lymph node rich sites like the axilla and the groin of younger patients. It almost presents as an enlarged lymph node. So these kids come to fruition and they're like, oh, this patient has an enlarged lymph node in their groin, let's biopsy it or take it out. And it looks like this bland kind of plump epithelioid to spindled thing with, if you're lucky on a biopsy and you get the center, you might see these pseudoangiomatous spaces. If not, you might just get this kind of nondescript spindle cell lesion that can sometimes have EMA or CD99 or Desmond, right? So those are your potential clues. If you're in a young patient and you're in the right site, then you can think about doing ATF1 gene rearrangement to prove it. Generally, they'll excise these then, but sometimes they metastasize to actual lymph nodes, right? Even though they sometimes have a lymphoid rim, they're not thought to be arising in lymph nodes, but they can metastasize to them, even following excision. So that's, yep, that's the end of the fibroblastic fibrohistiocytic kind of melange. In the last few minutes, is there a particular thing you wanna talk about that we haven't yet? Is there a particular tumor you're curious about, or a particular subset of tumors that you're curious about? Or should we just stop? Those are your options. Ryan, you're gonna say something.
I was gonna say vascular, but then it's like, is it gonna be like last time where it's like, how much into it are we gonna
How
get
would
before?
you, yeah, I know,
Yeah, I think that's the thing that these categories are, there's so much to learn.
yeah,
I guess we can cite a certain amount of it we want to go into, maybe start vascular.
yeah, let me,
Or any other one too, I mean, myogenic too is also.
okay, let me. Oh, there it is. All right, so you now, well, you should eventually have the link to this PDF. So you can look at your arrangement of benign adipocytic tumors. Look at these, cause they're super common, right? Tumors of fat, we see all the time. Lipomas, angiolipomas, spindle cell lipomas. We see fatty sarcomas all the time, right? Well-diff, D-diff liposarc, myxoid round cell liposarc, pleomorphic liposarc, so you can look at this on your own if y'all would like. We have, you know, leiomyosarcomas. The one thing I will say is that the threshold for malignancy in soft tissue is much lower than the threshold for malignancy in the GYN tract, right, like in the uterus. So an atypical soft tissue smooth muscle tumor is a sarcoma. An atypical, you know, GYN smooth muscle tumor is not necessarily a sarcoma, all right? So just be mindful of that. Very rarely you get these skeletal muscle benign rhabdomyomas. More commonly, right, we'd be dealing with a rhabdomyosarc, whether it be embryonal or alveolar or even spindle cell. There are some small round blue cell tumors that you can look at here. Various subtypes of rhabdo, various perivascular myeloid tumors like glomus or angioleiomyoma. All right, vascular. So 5 minutes. So look in the WHO again for your more full vascular tumors, but these are ones that we see more commonly, right? So just like with other soft tissue tumors, there's obviously benign, there's obviously malignant, and then there's intermediate or of low malignant risk. So the one that we see commonly in kids, right, is infantile hemangioma, which is characterized by clinically rapid growth and then kind of slowing and regression. If these get excised or biopsied in the rapid growth phase, you'll see these very plump, kind of rich vascular channels defined by, right, GLUT1 expression in the endothelial cells. So, right, GLUT1 is glucose transporter. Remember that there is glucose transporter on the red blood cells. So you'll see the red blood cells picking up. You should also see the actual membrane of the endothelial cells. That's the diagnostic of infantile hemangioma. It's interesting, it's curious, I usually do it to prove that it's positive, but it's usually a clinically obvious. Here's where we get into a little sometimes stick, are these epithelioid hemangiomas. So epithelioid hemangiomas can be richly cellular. They can have endothelial cells that are extremely plump and start to worry you for angiosarc. What sometimes, but not always, they'll have the background eosinophils, because this sometimes was called a lymphoid hyperplasia with eosinophilia. Unlike if you see a vasoformative epithelioid plump cells that you can prove are endothelial, right, with your endothelial markers. What's differentiating often these from a true angiosarc is that they tend to maintain pericytes around them. I didn't have this written down here, but they tend to maintain the SMA positive layer around the periphery, unlike vasoformative angiosarcomas, which are arguably even more cytologically atypical and do not have an SMA pericyte layer. But they are different from hemangioendotheliomas, which essentially are non-vasoformative, right? So epithelioid hemangioendothelioma is not really in your differential diagnosis of epithelioid hemangioma, right? Because epithelioid hemangioma is a non-vasoformative thing that has these nests and cords and strands of cells in this matrix. The only implication that you get that this is a vascular neoplasm is these blister cells, which sometimes have red blood cells in them, because they are trying to form these little abortive vessels, right? But when you do your endothelial cell markers, they will be positive. Your CD31, 34, ERG, whatever. The issue is these also can have keratin, right? So we don't want to mistake this for an infiltrative carcinoma. Always, throw on your vascular marker. Otherwise, this is generally relatively bland. The issue is that they can metastasize. They can be present in multiple sites, which are thought to be all metastases of the same lesion. They can be present in visceral organs and bones and soft tissue. Disease defining is the cancer gene rearrangement. So when we think about epithelioid, as I said earlier, hemangioma versus hemangioendothelioma versus angiosarcoma, morphology is generally strikingly different. Angiosarcomas are, so angiosarcomas are not a uniform entity, right? You can get the primary skin angiosarcomas in the scalp of old people that are highly infiltrative and really hard to excise without taking off their entire head, right? We see this from Gui and Blair and stuff all the time. You have the soft tissue or the deep angiosarcs that occur in non-sun exposed sites, like your deep or your intramuscular tissues. We've even seen primary angiosarcs, for example, of the parotid glands, right, that have nothing to do with the skin. That's generally of these epithelioid or vasoformative morphologies. Then you have angiosarcomas either in the breast or related to radiation, right? So primary breast angiosarcs are deep, are in young people who have not been previously exposed to radiation and can be deceptively bland. So we often work with the breast people to look at these, right? You can also get these post-radiation either true angiosarcomas or atypical vascular proliferations that occur generally in the skin or even in we're now starting to see these in the vulvovaginal region of patients who have had radiation for cervical cancer, et cetera. But it's similar to the same concept of the people who've been radiated for breast cancer, is that they get these atypical lesions that proliferate in the collagen of the overlying skin. If you have radiation related angiosarcoma in any of these regions that have been exposed to radiation, these are amplified with MYC. So we've used amplification of MYC in certain circumstances that we're not sure whether it's full-fledged angiosarc or just an atypical proliferation, because it's behaviorally correlative, right? So once you get amplification of MYC, then you are behaviorally like angiosarc, so you can call it angiosarc with the appropriate morphology and history, okay? So don't call it Kaposi's to Dr. Kraus. It's Kaposi. He's Hungarian. So Kaposi sarcoma is also not a uniform entity. What is uniform is the morphology, the association with HHV8. And the fact that you can use HHV8 IHC to diagnose the fact that this spindle cell lesion with extravasated red blood cells with eosinophilic globules is Kaposi's sarcoma. What may help you, but what may not help you is, does this patient have immunocompromised state like AIDS? Do they have an immunosuppressed state like organ transplant, right? Because this is a similar immunosuppressed state. Are they of an endemic African population that doesn't have an immunosuppressed state? Or are they these elderly Mediterranean dudes that also get this? So those are the kind of 4 types of clinical variants that we see, but they all look the same, right? So the background doesn't really matter. Okay, those were most of the vascular tumors. The other thing that I didn't mention were there are now other morphologic variants of hemangioendotheliomas that are not just, the classic one is EHE, epithelial hemangioendothelioma. But go to the WHO and remind yourselves of the other morphologic variants of hemangioendothelioma. Probably one of the trickier ones is the pseudomyogenic, because it will show you nothing vasformative, right? It will show you no red cells, it will show you no blood vessels, it will show you no blister cells, but it stains for ERG and CD31, but it also stains for SMA and keratins. So it's got this weird hybrid immunoprofile. It tends to be in muscles and bones, and it's again defined by this gene rearrangement. So why it's called a hemangioendothelioma, I don't know, because it has ERG and CD31 expression. To be determined if this stays as a hemangioendothelioma, but right now it is. So, yep, those are the vascular. Oh, hi. All right. Sorry, we have a meeting for a different project. Okay. Does anybody have any questions or comments? Okay. This will be there for you on the PDF. If you ever, on any of the other sessions, if you ever want me to continue and finish the morphologic subtypes that you can't see it, that I didn't cover, let me know. Otherwise, they'll be in the presentation and we're good. All right.
Thanks. Thank you.
Good, your autopsy today. This third.
Well,
Oh, okay, right. We didn't do the first one.
oh, we didn't do the first one.
That was a
Hello.
CJD brain, yeah. CJD brain.